procedures. And these connective tissue replacements can involve the allografts and several xenografts that we have on the market. The studies were done for almost all of them, and but I started about 20 years ago working with the allograft, which is alloderm, which is a human-derived, made from human skin, donated human skin in the United States. But most of the material was done for both. Was done for all materials. Some difficulties here, but let's see.
Is there a problem, Dr. Arthur?
Yeah, sometimes the screen doesn't go forward, but I'm working on it here. Let's see. Okay, there was something on the screen here that was freezing it. Now, for root coverage, we all know that the connective tissue, autogenous tissue, is very successful and very predictable. And there's no problem with it to achieve complete root coverage. It's very good. The only problem is that you have to remove it from the palate, a second donor site. And that sometimes or many times causes a lot of problems. Pain, of course, because the anesthesia is already very painful in the palate. And then post-operative pain, discomfort, morbidity, and all these well-known factors. But to me, also one of the most important factors is the limitation of the amount of donor tissue, not in length per se, right? You obviously have a limitation in length, but in the thickness. It's very common for you to find patients with a low palate vault, and the thickness of the tissue is between 3 and 4 millimeters, which is very thin to get a connective tissue graft. In order to avoid necrosis of the flap when you are removing the connective tissue graft, you need 1.5 millimeters of tissue on the flap, because 1 millimeter is epithelium, and epithelium is not vascularized. So if you don't have 0.5 millimeter of connective tissue underneath it, together with the epithelium, you get necrosis of the flap. So you need at least 1.5 millimeters for the flap. You need at least 1 millimeter for the graft, for the autogenous graft. It would be better to have it 1.5 millimeters. And you need to leave 1 millimeters for the periosteum to protect the bone. So if you add that up, it's about 4 millimeters. So ideally, you need at least 4 millimeters, and there are many, many patients where you don't have that. So if you don't have an alternative material, you will remove an epithelium and connective tissue graft, and you already make the ulcer on the palate yourself. So this is what we try to avoid using the allografts and the xenografts. So I prefer to use as much as I can the allografts and the xenografts to avoid doing that kind of discomfort and problems for the patient. No matter how experienced you are, in any procedure, you always will have some cases where you're going to have problems. So I prefer to avoid it. Now, it's not always possible, okay? Sometimes there are some situations where you cannot use the allograft or xenograft, and you have to go to the connective tissue. Very well, then you do what you must. But in our school, we have been working with these materials for a long time. Many. Pardon me? Sorry? Somebody said something.
Sorry, doctor, you can complete now. Okay,
there's some
doctor.
people with the microphone on.
Yeah. Sorry, we will fix it.
Can I continue now?
Yeah.
Because, all right, thank you. So we started, as you can see, with our first publication on root coverage in year 2000. The paper was published in 2001. The study had to start in 1999, more or less. So we have the 6 months publication and also the 12-month publication. And in this study, we had 17 patients because that's what the power test tells us to do. I'm sorry, but there's many of the people in the audience have the microphone on, and it's making a lot of noise.
Yes, doctor.
Okay, thank you. There's a lot of people speaking. So in this first group of studies, we use
no, just because it's their first time to use WebEx, so they don't know that that's their voice. We hear them just seconds, and everything will be mute.
Right. So maybe I can say that to the audience, everybody. I hear everybody. There's a lot of people talking on microphones, so you have to turn off your microphones because you can hear everybody. Okay. Thank you. So we use the blind patients and all the classic methodology, and on the control group we had 15 recessions, and in the test group 15 recessions as well. On one group we used the connective tissue graft with the coronal deposition flap, and on the test group we used the alloderm with the coronal deposition flap. There's still someone with the microphone on. It's very annoying. Please. Now, okay. So here we have the results. The gingival recession initially was 3 millimeters about in average. And when we use this connective tissue graft, it diminished to 1.13 at 6 months, and then 12 months to 0.5 millimeters. That's what was left in recession. For the alloderm, it's 3.23 and 1.3 at 6 months and 1 at 12 months. You can see that the baseline is larger for the alloderm. So when we compare how much root coverage we got between them two, we got a reduction of 242 millimeters for the connective tissue graft and 2.23. So they were about the same, but we did not use the pellets. So this is already a great advantage. This already tells you to use the materials. If you have the same result without having to take tissue from the pellet, it means that the material is better for the situation. I'm going back one slide because this is very important. Now somebody is covering the screen here with, in this case, but DD. You can see that we use a trapezoid. Let me get we did a trapezoid flap, right? Which is usually designed for this purpose. Okay. So the trapezoid flap is the flap that is traditionally used for the connective tissue. And in this study, this is for a single recession, right? If you do multiple recessions, it would be the same. So we did the same technique, the trapezoid flap, suture the graft at the CJ, and then we covered both materials with the flap. Okay, so we use the same techniques for both, and we got similar results, which is an advantage because we did not remove tissue from the palate. So it is a material that can be used to replace the connective tissue graft. But we wanted to improve this a little more. We thought that we could improve the results with the allograft. Why? Why? Because both materials are different. The autograft, when you remove it from the palate and you quickly suture to the periosteum, and you should do that, okay? I see many students and colleagues that put the graft in some saline and then suture the palate first. That's a mistake. Take the graft and suture it first to the periosteum because it has the graft, as we can see here, it comes with vessels, it comes with cells, but they don't stay there for long. It's a live tissue. But as long as longer you leave it out of the mouth, not receiving the blood, it will start to, the cells and the vessels will start to disappear. Okay. Now, the allograft or any graft doesn't have the vessels, it doesn't have the cells. It's just an empty 3-dimension collagen fiber matrix. So it takes longer to heal a little at the start. When you use the autogenous graft, you already put it on the periosteum, and almost immediately the blood goes into it, and the anastomosis with the blood vessels that are existing there fibroblasts start to migrate into the autogenous graft, and that takes longer for the alloderm or for the xenografts. So we consider that was not fair to use the same technique for both. The alloderm needed a special technique to get more blood, to get more cells into the healing so that it could have an advantage or at least the same chance as the autograft. Remember that with the same trapezoid flap, we got similar results, but we were trying to improve to make the allograft even better. So then we changed our study. On both sides here in this paper, we used on one side randomly the trapezoid flap, which is the traditional one, and you can see the trapezoid. You can see the trapezoid design, and the graft is adapted, sutured at the CJ, and then the flap will cover everything. You'll be very near to the releasing incision, as you can see, and you get in. So this gets very little blood supply because the flap is very thin, is very short, and the periosteum also is very short, so it's very little healing potential there. Now, what we decided to do is to use the extended flap. So we go 1 tooth more to each side, 1 tooth more to each side, and then you have an extended flap. And when you have the extended flap, you have more blood supply and more cells going to the area. And that will probably improve the healing. So let's an example of the situation. On the top line, you have the trapezoid flap, and on the lower line, the lower row, you have the extended flap. So initially, all our studies, the initial recession is larger than 3 millimeters, because we have evidence that the smaller the recession, it's easier to cover. So when you have 3 or more, it's a little more difficult. So when you read the papers and you see fantastic results, go and look at the mean baseline size of the recessions. If it's 2 or less, then anything would work. Now we have the trapezoid flap on the top row. It's a split thickness flap, so there's periosteum covering the bone. We do a light scaling in root planing, and we use EDTA 24% gel on the root surface for 2 minutes, not on the enamel, okay? Will cause sensitivity. It has to be on the root. On the bottom, you have the extended flap and the periosteum, and we do the same approach. As you can see, this is the tooth in question. We just go 1 more to each side to increase the area to get more blood vessels and more cells into the area. And the connective, the alloderm is sutured at the CJ. I'm mentioning that because we're going to change this a little bit in the future papers, and as well on the extended flap. You have to maintain it in the only tooth, in the tooth that you're treating. If you make an extended flap and then you also make a large graft, it doesn't work because you're repeating the same thing. You're reducing the healing to that graft. If it was a multiple recessions, we will still go 1 more tooth to each side, and then you can use a larger graft. But if you're treating a single recession, it has, even though the flap is extended, the graft has to be in the tooth itself. It should not extend into the other areas. Then the flap is coronally displaced to cover all the graft, right? And then we have the 6 months result. Like I said, this is the tooth in question. So the result is much better. Already you can see it has a better flow, a better soft tissue appearance, and the root coverage was 100% here. Now, people ask, you may damage these teeth. the adjacent teeth. But measured the adjacent teeth as well. The parameters that we use, all the clinical parameters, we also use on the adjacent teeth to make sure that we did not harm them, okay? Because this is a question that could be asked. So the results we have, the initial recession was 3.4 millimeters for the control, and we finished with 1.3 millimeters. The test group, the extended flap, the baseline was even a half a millimeter larger, and we still got a better result, 0.9. These are from 17 patients, okay? Split mouth. Okay, so one tooth on one side and the other on the other side were treated on all the patients. And so this means that we got 2.1 millimeter of root coverage for the control group for the trapezoid incision, and 3.6 millimeters of root coverage for the extended flap. So you see how much we improved the result there by using this technique. So these are the results of the adjacent teeth, as you can see here. We also measure them so that the reviewers of the papers will say, well, but you're treating the teeth on the side and you may cause problems there. So we measured, and in actuality, we also got improved for all parameters because of the coronally displaced flap. So the teeth, adjacent teeth, also got improved results. We asked another periodontist and the patient to evaluate the results at 6 months. In this case, it's still 6 months, to evaluate the results themselves, which they thought was better, the modified flap or the conventional flap, or if they were the same. So both the periodontist and the patient, we made an average, they thought that 81% the side with the modified flap was better. And we used the extended flap because the study by Mormon Ansel, 1977, you see, there's the papers never become old. There's always information. So 1977. And the thing is, when you extend the flap, because the blood vessels, they come from the bottom of the vestibule. I'm having a problem with this. The blood vessels come from the bottom of the vestibule and migrate parallel to each other coronally. So like this. Not like this. It comes from the bottom of the vestibule, and the blood vessels will go up into the gingiva parallel to each other. So the more extended the flap is, more blood vessels and greater availability of cells and more nutrients you have on the extended flap. So that's the rationale. As I mentioned to you before, when you have, these are the connective tissues, right? Just the connective tissue, some of the traditional studies, and it shows that when you have 3 millimeters of baseline recession, you got 81% of root coverage. In this case here, when you have 45, you had much less. And the same we found for our two first papers published in the Alloderm was Aisha Reddy, published 1 month before me, and she's got 66% of root coverage with a 2.5 millimeter baseline recession. And we got 3.23 initial recession baseline and also 66%. But with this study, with the extended flap, the recessions were mean. The mean recessions were 4 millimeters amount, 3.9, and we got 80% of root coverage after 6 months. So this confirms how much better the study is. And we also have the result from this paper after 36 months, 6, 12, and 36. This is the time that we followed up. And you can see the results here. The gingival recessions, initially for the conventional technique was 3.3, and 36 months it was 1.4. For the modified recession, it was 3.9 for the modified technique, 0.7 after 36 months. So on average, 17 patients, on average 0.7, it's almost complete coverage, right? And all the results were statistically significant. And when we compare the initial and the 36 months for all of them, we got very highly statistical significant difference, 0.001. For the people that don't know much about the statistics, this means, saying it very simply, in layman's term, this means that we have one chance in 1,000 that this result is a coincidence. And so 1 in 1,000 is a coincidence. All the rest are because of the technique. So that's why it's a very highly significant statistics. That's what it means. And here we have the results. The modified technique on the top, and on the bottom we have the conventional technique. I know that in the lower teeth is a little harder to get more coverage, but we have about half of the sites from the top arch and about half on the lower arch. So when we do the mean, they equal. So in this case, we use maybe not fair. Should have chosen another tooth because this was a cuspid, very thin tissue, and we still got a good root coverage and some attached gingiva, but a case selection there. But the average results is what matters. So for the conventional technique, we got 2.1 millimeters of root coverage, and for the modified technique, 3.3. So there's no question that extended flap is a lot better. Now, if you look at the comparative results, the blue bars are the conventional technique, and the orange is the modified technique. And you can see that we got 62% root coverage at 6 months, 60, 58 at 36 months. And on the modified technique, extended flap, we got 80, then 83 at 12, and maintain 83 at 36 months. So it's better, and it maintains. Now, going back to the periodontist and to the patient, you can see that at 36 months, 100%, both the patient and the other periodontist thought that the tooth that received the modified technique was 100% better. Okay? So there's no reason to question this. Some people in some places that I lecture ask me if this was already published. I'm sorry, I forgot to put the data here. If anybody wants a copy of these papers, you send me an email. Dr. Haza has my email, and you'll see it at the end of the session as well here on the screen. You can send me an email, and I'll send you the PDFs. Okay. So this is a confirmation, because somebody asked me in some places, well, if you use if you use the extended flap for the connective tissue, maybe it's better for the connective tissue as well. So we did, just to show, and we got the results. Okay, so modified technique for the connective tissue, a modified technique for the alloderm. So both had the extended flap, both. The other studies were on both sides was the alloderm or a xenograft, mucografts, mucoderm, any material. Now we're using the connective tissue just to see if this technique is better for the connective tissue as well. So we have on the top, we have the alloderm, the top row, and on the bottom row we have the connective tissue graft, and you can see that the results are very similar. And when we did the measurements, you can see that we got just about the same coverage, the recession left, about 0.5 millimeter of recession, and maybe a little more on the alloderm. But because of the baseline, but when we compared the amount of root coverage that we got both about the same, 2.6 millimeters for the connective tissue graft and 2.59 for the alloderm. So the extended flap is better for both techniques, for both material. Now, finally, we also modified one step more. So now we have the final technique, the one that we use on all cases. Now we're happy with the results of this study here. Because in the previous studies, in some cases, we had a marginal exposure of the graft, about 1 millimeter of exposure of the graft. And since it's not vascularized, it's not a living tissue, the grafts, the replacement grafts. If they are not covered by the flap and they are sitting on top of the tooth, it's gonna necrose. So in some cases, we lost about 1 millimeter of the graft. So in this technique now, we thought that we could eliminate this problem by first using the extended flap, the same thing as usual, and now suture the graft, the green line, 1 millimeter apical to the CEJ, 1 millimeter apical. And the reds, which is the graft, the flap, we suture 1 millimeter coronally to the CEJ. So there is a distance of 2 millimeters. There's a difference of 2 millimeters between the flap and the graft. So in this case, even if the marginal tissue contract a little bit, there's no chance that the graft will be exposed. So the control group, extended flap, as we described previously, and the experimental group, extended flap, but the alloderm was sutured 1 millimeter below the CJ, and the flap sutured 1 millimeter above the CJ. And this is what you have here. This is the alloderm sutured at the CJ, and the flap was also at the CJ. And this is the result. Here, we suture the graft 1 millimeter below the CJ, and the flap 1 millimeter coronal to the CJ. And this is the result, 100% root coverage here. So it is, we feel that it is better because none of the cases we got exposure of the alloderm. Let me go to the results here. You can see that as far as root coverage, we have 2.18 millimeters for the control and 2.92 for the test, which is the modified positioning of the test of the graft and the flap. This is what we use to make sure that our results are precise, but you don't have to do that. You can use normal measurements. We have a patient sitting on this little device, which is like something like when you go to get your eyes examined. So she has a fixed position of the head, and the camera also moves up and down, side to side, and has markings. So when we photograph the tooth that we're going to measure, we make the markings in which position the camera was. So 6, 12, 36 months later, we go to the same measurements. So the teeth are photographed in exactly the same position. And then you have a free software that you can download from the computer, and it does all the kind of measurements that you want. This is called the Gingivo Morphometry, but not it didn't catch on. Not many people use because it's a little heavy and very a little uncomfortable for the patient, but it has very precise, gives you very precise measurements. And this is with already published with the 12 months. So you have here the initial, it's the cuspid, and with 12 months. Right? In 12 months, this is the tooth. We also got a coverage here, and the tooth 100% root coverage. And look how nice the appearance of the entire gingival tissue appears. It's very smooth, very anatomically perfect, right? So this is the technique that we stick with. There it is. Okay, this is the technique that we prefer now. And if you look, and we do it in all the studies we do today with the xenografts. There was another one came out now, the Fibro Guide, which is a very thick, that will improve the tissue thickness. So for our study here, in this case, we had 3.32 initial on the control and 3.30 for the test group. Now test with the there was a 2 millimeter difference between the position of the tissues. So the baseline they were the same, and then we have 0.71 millimeters left of recession in this case, and 0.2. I mean, on 17 patients, an average of 0.2 is 0. This kind of indicates that we got full root coverage on all the patients. Well, there we go. So that, to be very precise, with the test group where we have the difference in the position of the graft and the flap, 92% of root coverage and 78%, which is also very good, considering that we have recessions that were about 3.5 millimeters, which is large. And so much better odds of getting complete root coverage when you use the extended flap in these different positions of the allograft and the xenograft. So with these techniques...
Dr. Arthur?
Yes?
Sorry for your interruption, but we just have 1 minute. It was a very interesting lecture, but because of the next lecture.
So yeah, I'm finished. There we are. This is the last slide.
Okay.
No, that's okay. So, so it's much better. Now, we also have other studies with smoking, using alloderm with in mucografts with endogain, all other materials, but it would be too long for the 30-minute lecture that they asked me to present. But if you look at this paper on Periodontology 2000 that was just published last year, March 2019, I was the main author. We kind of tell this whole story and much more that we will not be able to present today. Okay, so I thank you very much for your attention, and it was a pleasure to lecture to you. Maybe someday in the future I can visit you in person. Certainly much better. Huh? Personal contact. It's very strange to lecture to nobody because you don't see anybody. You're seeing me, but I don't see anybody. So thank you. Are we going to take questions? No? No questions. Ran out of time. I can't hear. Turn microphone on.
Thank you, Doctor, for your interesting lecture.
Okay.
Thank you so much.
No questions.
No questions. No time, unfortunately.
Okay.
No time.
All right.
Thank you, Doctor.
Bye-bye. Thank you.
Thank you. Dear doctors, our next lecture will be at 3:15 after 4 minutes, inshallah, with Dr. Rawat Sambara.